Good afternoon, everyone. On behalf of my dream team at EXCO, RGS EXCO, my esteemed panel of speakers, the Reflection family, I bid everyone a warm welcome to our RGS medical and financial planning webinar. This meeting will be recorded as well as live streamed on our Facebook. The speakers will share first, and then we'll open to Q&A thereafter. As we know, the life expectancy of Singaporeans is among the highest in the world at 81.4 and 85.7 for men and women in 2019, respectively, according to the public sector report prepared by the Ministry of Finance. The health-adjusted life expectancy is also among the highest in the world at 72.6 and 75.8 respectively for women, for men and women. So as you can see, about 10% of the adult life is spent perhaps coping with health issues. This afternoon, we have a great team of speakers who will be sharing with us ideas on how to add life to our years. Without further ado, I would like to welcome my first speaker, Junus Eu. Ms. Junus Eu is the co-founder of StrongSilvers, and she's from the class of 2004 from Tarbert House. Junus is an RGS alumni from the class of 2004 and is currently running her age tech business, StrongSilvers, after spending a decade in venture capital investing in technology businesses in the US and South Asia. Junus is passionate about exploring what it means to age well and is also an Alice Lim Memorial Fund gerontology scholar under the SUSS S.R. Nathan School of Human Development. She was also in the handbell choir in RGS and currently continues to pursue the arts through competitive dance sports. Thank you, Junus, for sharing your ideas with us this afternoon. And on longevity, more than diet and exercise. Over to you, Junus.
Thank you, George. Let me just share my screen. Let me know if you all can see.
Yes, we can.
All right, so thank you everyone for joining. And today I'll just start off the session talking about longevity and how it is more than just diet and exercise. So as George rightly pointed out, in Singapore, we are looking at a life expectancy of 83.6 years compared to 76.1 in 1990, just based on the latest data. And we can see the upward trend, right? Of course, like, between the males and females, we can see the upward trend of life expectancy in Singapore. And by 2030, we'll be expecting 1 in 4 people will be over 65. Right? That means that, when we're out on the streets, 25% of us will be over 65. And by 2035, it means that every 1 out of 3 people will be over 65. So we clearly can see how Singapore is an aging economy and an aging country. But it's not just about the longevity, but it really is about the good quality longevity. So Josh talked about lifespans. We also talk about health spans. But onto a more somber note, because we've seen in the recent last few weeks where we've seen the news of Singapore's over 60 population, seeing the highest number of suicides since 1991, where unfortunately we've seen 154 seniors take their own lives in 2020, which is a sharp increase from 2019. And this is probably brought about by that social isolation during the COVID period. And let's look at let's take a look at what we've been seeing on the news in 2021, where we're seeing that we have seen the highest number of suicides since 2012 during the COVID-19 period. And we go back 3 years in 2018, this also made the headlines, where we're seeing the number of suicides committed by the elderly hits record high as Singapore population's ages. And even we go back another 3 years, we're already seeing more seniors in Singapore taking their own lives. So this is a very, it is a sad statistic because, even though we are a country that has one of the highest life expectancies in the world, we are also seeing this depressing trend of our seniors taking their own lives, despite the quality of, quality of care increasing. So why is that the case? So as we age, one of the things is, as we age, as we progress from, let's say, a working adult to retirement, it often is the case where transitions in life are the most painful. So as one ages, typically we see our identity, be it a provider, a protector, a careerist, and all the different roles that we serve, these change. And as one moves towards that stage in life, we are also forced to deal with changing identities, be it in physical, aging, financial, and also professional. And on this note, I wanted to share actually a book that I've read, which has been very illuminating when it comes to longevity, because if you look at the cover, it says how friendship, optimism, and kindness can actually help you live to 100. And where we're talking about longevity, I thought that this was a really interesting topic to look at. So what this book actually talked about is how actually a strong support network of family and friends actually can lower mortality risk by around 45%, whereas exercise only lowers it about 23%. If we look at additionally, volunteering can lower it by 22%, while certain health fats like turmeric hasn't been shown to help at all. So this kind of is an additional element, right? Because so much of the industry is so focused on diet, exercise, which is all well and good. But when we look at Singapore's example of why, adults, why our seniors are actually taking their own lives, we need to consider the social and emotional aspect of aging as well. So in addition to healthy nutrition and physical activity, it is important to look at stronger friendships, stronger social connections, practicing empathy, and also looking at what is one's purpose in life when we look at improving our own lifespans as well as health spans, which is in general looking at increasing.
I don't want to see that white sign. You see, I can't read. So I want to leave that.
Go it.
Yes.
And how do we mitigate this? And more importantly, how are we truly addressing the aspirations, challenges, and concerns of our seniors? Because this is always something that I talk about, right? When we look at the increasing lifespans, longevity, when we look at the senior category, right? One day it will be us, right? It is either we die early or we get there, right? We pass the age of 60. And it's not as if people change once they go past the age of 60. So what is the reason for, for example, ageist notions that are very prevalent in workplaces, especially in technology companies? What is the reason why there's so much ageism even in marketing, where, someone who has wrinkles, especially for women, could get a lot less jobs? So if we look at, Hollywood, there's also this gender imbalance when it comes to aging, because for the men, they're okay with, having the wrinkles and maybe even a pot belly, and sometimes they're celebrated for that. But for Hollywood actresses, it's very difficult, and they have this additional burden of, looking as young as possible, doing all this Botox and all these fillers that, their male counterpart might not necessarily need to do, right? So I wanted to talk a little bit about the new third act in life, where we look at, specifically the third act, because we are familiar with the first act, the second act, where, first act basically talking about our childhood growing to adulthood. Second is, the bulk of our career planning, family, bringing up the family from a financial perspective, saving for older age. But it is the third act that, we actually wanted to celebrate today, where we're talking about transformation. We're talking about still seeing meaning in life after retirement, and actually seeing it as the best time for your own opportunity for growth and development. Because it shouldn't be the case that once somebody retires, they're seen as, not useful to the world, but actually the reverse is actually true, because these people are the ones with a lot of rich life experience. They're the ones who really can tell their stories, and young people like us can really learn from it. For example, like Auntie Betty on the call, there are so many things that we can learn from her, right? And I think that is so essential to capture that, because there's also the additional element of dementia that sets on. Dementia is yet another issue that we'll talk about later on this talk. But there is an element of, all these precious memories and experience that is actually lost due to the ravages of dementia or other, mental related condition. So what we're building at StrongSilvers is, we believe that our seniors are valuable resources, and we want to help them tell their stories. So one of the, the lady in the middle, Ong Bien, she is a very interesting story. So when I met her, she, she'll tell you about how she absolutely hates taking photographs. When she goes on trips with her family, she doesn't even like to be photographed because, she just doesn't want to, just does not like to be photographed. But she herself wouldn't have been able to foresee that at age 65, she would be actually succeeding as a model after her retirement. And it is not just about the, let's say like finding a new lease of life with modeling. She actually related to me that after she started taking on modeling jobs and, being interacting with the younger generation and, learning new things like social media, it actually helped her be more sharp, because she found that prior to that, she was actually losing memory with regards to remembering certain things. But after, she actually said, she actually saw a marked improvement when she started interacting with younger people, learning new technologies, trying out new things. And then she felt that, her mind was sharper. So, there's actually an additional benefit when it comes to, engaging in such things. So in short, our mission is to be a community platform that empowers silvers to be content creators. And just to end off, for the RGSA webinar attendees, we've also tied up with Singapore's largest suppliers of, dried herbs and nuts, seafoods. And so if you're interested, we can send samples to those who join this link. So just scan the QR code, because what we're looking to do is to cultivate more senior influencers. So if people actually share their experience post using, for example, the samples, that's something that we're looking at as well. So George, I'll leave you to carve out some time for Auntie Betty.
Thank you so much, Junus. You really have a heart of gold for the silvers. Ladies and gentlemen, you look at Junus, she's a millennial, and she started an age tech company, to celebrate silvers, to cultivate them to be influencers in the next phase of their life. Next, I have the privilege and honor to introduce Auntie Betty. Auntie Betty, could you unmute yourself? Yeah, Auntie Betty is amazing. She's 94. If you look at her, you can't tell that she's 94. Shimi, could you help me pin Auntie Betty, please? She's a role model to me and to many of us. She has been the past president for 25 years of the Chinese Women Association, and she lives a life of service to the community. So I leave it to you. I leave it the time to you, Auntie Betty, to share your take on how we can add life to our years. Over to you, Auntie Betty.
All right, here I am. Thank you for the introduction, George.
Yeah, my pleasure.
Yes, I want a light. I think I must be one of the oldest Silver Raffles alumni members around Singapore, and I'm delighted to join all of you today. You want to know what I've been doing now? How I spend my time? Well,
yes.
I've been doing a 4-year Bible study course run by the Wesley Church, and I'm in my last final year. I decided that I should do this before I meet my maker, and it has been most interesting and revealing, and we do this by Zoom, and we have great fellowship. Can you see me? Yes. Oh.
Yes, perfectly.
Yes. I'm sorry, I shouldn't have been holding up the paper.
Oh, that's quite all right.
Yes. I've also been in touch with family and friends with WhatsApp. And isn't that a marvelous thing, WhatsApp? And to relax and keep my mind alert, I play Free Cell, Solitaire, Mahjong on the computer, and Rummikub, and I'm having a good time every day. My advice is tell people you love that you love them at every opportunity. And always remember, life is not measured by the number of breaths we take, by the moments that take our breath away. I keep very busy because I keep in touch with all my friends, and I think you must never be lonely. You must encourage I encourage you to use WhatsApp and contact all your friends. I hardly go out. My family does my shopping for me. But I mean, I keep myself very occupied at home. What else do you want me to tell you?
You're so wise, Auntie Betty. You've got so much to share as to how you add life, to your years. How you've been involved with the CWA and, reaching out to the community, serving the community, and just
Well,
helping out, contributing to some parts of the community as well, even though you're staying at home. Yeah.
Yes. Well, I did. I'm 94 years old now, and I came to Singapore in 1933 and joined RGS in Queen's Road and studied there until December 1941, having completed junior Cambridge when my family was evacuated to Australia. My fondest memories of school culminated in the 111th anniversary celebration when I was invited to take part together with the other old girls in a concert.
Yes.
I returned to live in Singapore in 1969 and immediately joined the Chinese Women's Association, where I served until it reached 100 years in 2015. The major social service activity was to run the Henderson Home for Senior Citizens. And at the time, the workers in Southbridge Road would sleep on top of the tables where they sold their products in the daytime. And the social service vans would pick them up and we would give them a home. And that was the first time that a senior citizen home existed. And we've been doing that all these years. The home still exists.
Yes.
But we are not running it anymore. We gave it to the trade union, NTUC, to run. And they're doing a very good job now in Bukit Merah.
Yes.
But we still support them, and I'm a patron of the home. So I spent a life doing social service for the community, and that's been very rewarding for me.
Yes. Yeah. Thank you so much, Auntie Betty. You're an inspiration to us. You started the old folks community for senior citizens, and you're still a patron with the Henderson Home. What an inspiration you are to us. And to look at you, it's such a picture of health. Seriously, just makes us want to, really learn from you.
Well, I think that you must never be lonely. You must always have friends. And WhatsApp is a wonderful way to connect. In fact, we connect more than we used to do before because it's so easy on WhatsApp.
Yes, yes. Yeah, like what Junus say, social engagement is so important to
it's very important for your psychology, for your mental health. It's very important. And to enjoy life, enjoy friends.
Yes, you are a strong silver influencer right here with us, and we're so grateful to you, Auntie Betty. Yeah, do continue to stay with us for this Zoom, and there's much we can learn from you as well, right through. I would like to put this time over to Goh Soo Yan, Dr. Goh Soo Yan. She's the chief of my medical task force to getting doctors to speak at our medical webinar. Over to you, Soo Yan.
Thanks, Jock, and thank you, Junus, and thank you, Auntie Betty, who really embodies the idea of active aging. So we have 3 more speakers for you this afternoon, and it is my privilege to introduce each one just before they speak. And first up, we have Dr. Nur Farhan. She is a specialist trained in geriatric medicine, so she is a national treasure because geriatrics is so important. Farhan is now practicing at Raffles Hospital. She is a regional and expert in issues around aging and geriatric medicine. Farhan received an MBBS from Faculty of Medicine, NUS, and is also a fellow of the Royal College of Physicians, United Kingdom. She's an active volunteer in the community, and she has a great passion in increasing health awareness in the community. And she's also very active on social media. And she's got a great title for her talk today to us. It's Doctor, I Want to Live to 100. And I think after everybody has heard Auntie Betty, they're going to want to weigh in on this as well. But over to you now, Farhan.
Thank you very much, Suyan, for that kind introduction. Great. I am Dr. Nur Farhan Alami, and I am a geriatrician. So it's a little bit confusing when I tell people that my specialty is in older people, because the first question I get asked is, doesn't every doctor see older people? So that's true, but my specialty is really in people who have what we call geriatric syndromes. So I see older people with memory issues, for example. I see people who have problems with falls or nutrition. So besides being a doctor, I'm also a mother. I have 4 children, and they are aged between 1 to 11. So my son just turned 1 last weekend. So it's really busy because I work full time. And just juggling children while working in times of the pandemic, that was really difficult, because when school closed, that was really, really challenging because all the kids were at home and my workload had increased. So before I jump into the topic of today's talk, I'm going to talk about how you can live well, and I'm really going to be focusing on the mind. So before we go into that, I just want to talk a little bit about the challenges of, sorry, my slides don't seem to be moving very quickly. Yeah, just the challenges of mothering and doctoring, as I know that lots of RGS girls are joining us today. So welcome. I mean, it's great that you've taken time of your busy Saturday afternoon. I'm sure all of you are on TikTok. So that's something exciting that I started during the pandemic, and it all started when I got my COVID vaccine. It was really at a time where a lot of suspicion, there were lots of suspicions and false information going around about the vaccine. So I felt that I wanted to talk about how the vaccine was, how it worked, and to encourage everybody to go through vaccination. So then, I created a TikTok video, and since then, I created like a couple more videos about what it means doing geriatrics, how exciting it is. And it was a way to encourage young people to explore this field. Sorry, I'm trying to change my slide, but then there seems to be some, okay. So for young people, when I was a young doctor, it seemed like there were lots of misconceptions about doctoring as a woman. I mean, the first question that I was asked on my social media platform was, is it possible for doctors to get married? Does it mean that you enter medicine and then, you can't find a spouse? Well, I suppose that is a fear because, you're a young doctor, you're just entering work, and you want to find a partner as well because building a family is important. Well, I found my husband in hospital. We actually work together, yeah. So, I mean, there are men in hospitals as well, and medical people tend to marry each other. So don't lose hope. Even if you don't meet someone, there are lots of apps, there are lots of dating apps and platforms because, busy people, it's not just doctors that find it difficult to get a spouse. Lawyers, accountants, they're all in the same boat. So the other challenge that I found was that a lot of my friends, I mean, when you marry another doctor, sometimes you feel that one of you have to take a step back, manage the family while, trying to support your spouse, for example. And a lot of times, men, some of my friends, they've married surgeons and, it's they work really long hours. So there is some flexibility in a way where women are allowed to take more time with regards to pregnancy, medical leave. I mean, it is a lot friendlier now. I've got lots of friends who, who have pursued training, they've become specialists, and they've been given the option of doing part-time work. So these are some of the challenges that women face, but it's not impossible. And I think it's really important for us to be in touch with alumni because women support each other. And that's why I'm really excited to join in today's webinar. And, I've worked with Suyen. She was a great mentor and role model. So it's not impossible. There are lots of things that women can do, and you can have it both. You can have young children and have a fulfilling career. So jumping right in, I'm so excited that Auntie Betty is 95 and she's looking great. I want to be Auntie Betty. I'm sure all of us are in admiration as well. So to live till 100, you want to look after your physical health and your mental and emotional wellness as well. So the one thing that you need to avoid is dementia. So I'm going to talk about my personal experience dealing with patients with dementia every day. I think what's really important to recognize is that we should recognize dementia early. Suyen is an endocrinologist, so she sees diabetes. Can you imagine if you have diabetes for 10 years without treatment, then you want to start your diabetes tablets? Imagine all the complications that would have happened. You would have the complications of blindness, for example. You may have kidney failure. So dementia is the same. I tend to see a lot of patients at a late stage of diagnosis. And studies have shown that if you catch the dementia late, if it's already been going on for a couple of years, you don't respond as well to treatment. So the last question that I want to address is something all of us want to know, which is, what can you do to prevent dementia? It's really exciting because there's so much new research that has come out, and we know that dementia can be prevented. So there's this thing where I'm sure Auntie Betty would agree that age is just a number. So there's the biological age versus the chronological age. So your chronological age is the real number, so I'm 39, but perhaps my biological age, I'm hoping that it's 18. And that means that your body, your body is young, your mind is young and active. When I see a person who's 82, when I look at the registration form in my clinic, I have no idea whether the person that will come in would be on a wheelchair, being tube fed, or if this person is, is a CEO of a company. I recently met an 82-year-old who came to see me, and he said, "Doctor, I'm a little bit concerned about my memory because my children say that I repeat things." So he said, "I want you to look at this video." So he showed me a video of him being interviewed on the BBC, and it was perfect. So I asked him, "Oh, were the questions scripted?" Then he said, "No, it was on the spot." So that was a definite, besides asking him questions and assessing him, he did not have dementia. So it was an example of how active an older person can be. So here are some dementia facts. I've been often asked, "Doctor, why is it that dementia is so common? Is it something that we are eating? Is it, something in the water? Why is it that everyone has dementia?" So the answer to that is that we are living longer and longer. And Junus shared a lot of exciting statistics, Georg as well, that being old in Singapore, we are really, really privileged because, we are like number 3 in the world in terms of longevity. But here's another exciting fact. In 2050, if we have granddaughters that are born, a girl who's born in 2050 can live up to 92 years. So that's really incredible. And you would say that this is one of the greatest achievements, in the last 100 years, that we've really managed to make humans live really long. So dementia is a disease of the old. Perhaps I could put up that question. What do you think is the risk of a person above 80 having dementia? Like if we have 10 80-year-olds, how many do you think would have dementia? So about 1/3, 1 in 3 above 80 will have dementia. And if you're above 90, it would be 1 in 2. Yeah. So then the question is, if you're above 100, would it be 1 in 1 that you would have dementia? Well, my oldest patient is 105 years old and she has no dementia. She came to see me because she had a fall. Unfortunately, she had a hip fracture and needed surgery. So Suraya is going to talk later. Suraya is my friend for a very long time and she's an orthopedic surgeon. My 105-year-old patient walked out of hospital. It was really, really amazing. Her son was really conflicted whether mom should go for surgery or not. And her son was, if you can imagine someone is 105, her son was in his 80s. Yeah, so his son said, you know, I know mom is well, I know this is what she would want. So, you know, whatever happens, we'll give her the best possible chance. So that's the story of my 105-year-old. So dementia is increasing because of aging. And Junus shared this statistic where 1 in 4 of us would be above the age of 65. So there are 4 million Singaporeans, 1 million people will be a senior. So what's being done? I think the first important point is that longevity is opportunity. I mean, we talk about aging as if it's something bad, you know, like your kidneys get worse, your heart gets worse. I mean, Auntie Betty is going for like Bible studies. You're learning something new. It's an opportunity. Not everyone can grow old. So growing old is a tremendous opportunity. So there's lots going on across governments, across ministries, to make sure that, you know, the young look after the old, and we are not going to put 1 million seniors in nursing homes. Everybody is going to age in place. So I put up a picture of a man with a wheelchair. You can see that he's actually on a motorized vehicle, you know, he's on a motorized scooter. So this man was a polytechnic like technical, or he made things, he made electronic gadgets in a polytechnic. So his wife had dementia, and he found that she was very agitated in the house. But as soon as he put her on a wheelchair and took a long walk around the neighborhood, she became very calm. The problem was she became calm, but he became very tired. So he created a motorized device where he could sit, and you can see he's added like a little, you know, like a little canopy to keep her out of the sun. I mean, I really like this photo. So moving on to dementia, I didn't title my talk dementia and what it's about, because I think none of you would be interested to listen. But dementia is really important because either, you know, you may encounter someone with dementia in the family, or you may become a caregiver, and none of us would be prepared to do that. So it's important to know what it is and to identify what it is. The most common question I get about dementia is, what is Alzheimer's? Is it the same as dementia? So I would describe it as dementia being an umbrella term, and Alzheimer's disease being one type of dementia. The other common type would be vascular dementia. And I will talk a little bit about vascular dementia in a way that our brain is a very vessel-rich organ, so anything that affects the blood vessels can increase your risk of dementia. I would advise going on, I mean, just Googling Alzheimer's Disease International. It's a huge international organization, and they do lots of awareness on dementia. So these are the 10 warning signs. I want to share about some probably unusual ways that my patient presents, because, you know, when mom starts asking for breakfast again and again, or when dad wanders out of the house and gets lost, that's really not early dementia. You know, this may be in a dementia in the middle stage. And lots of times people don't, or families don't recognize what is dementia. They think that, you know, mom or dad is aging. These are just some of the changes. So I want to share about one of the patients that I'm looking after. She's actually a retired teacher. So my mother's a teacher, and I love teachers because I think that with you know, being in RGS, moving on, I've learned so much from my teachers, and they really inspired a passion for learning in me. So this was a retired teacher who was recently widowed. Her husband had passed away 2 years ago, and she became really bored and lonely. So at the age of 75, she decided to take on an adjunct teacher role in a school where she used to teach for many years. So she started this adjunct teacher role, and she was given a timetable, but no matter how the other teachers guided her, she couldn't find her way from the staff room to the classroom. And she managed this like a couple of years ago when she was well. So that was something unusual. And she started getting mixed up in with regards to timetables and who and when she was supposed to teach. So the thing was, she had no insight. She had no idea what was going on. But one of the teachers in the school, she was friends with my patient's son. So she called up the son one day and said, "Hey, this is happening." So mom, her son had also noticed some changes, especially since dad had passed on. So very commonly, when there's a recent loss of a spouse and suddenly the children are taking over, this is a time where perhaps when spouse was still around, they've managed to take over some tasks. But when dad has passed away, suddenly the children realize, hey, something's wrong. So her son had realized that mom had gotten into a series of road traffic accidents. And this is not an unusual way of of my patients presenting with dementia. So how she had gotten involved in an accident was that she was at a zebra crossing. So there was someone crossing the road and she just like knocked into him. So it wasn't like a parking accident, or it wasn't changing lanes, it wasn't negligence, it was at a zebra crossing. So that was very unusual. As soon as that happened, the son, like many children of my patients who have experience with mom or dad in a traffic accident, he took away the car. So he said, hey, the car's under my name, I'm selling it. Yeah, and this created a lot of unhappiness. So she would bug him every day about the car, like, give me back my car because I've been driving for over 50 years and I'm not going to take the Grab that you booked me. Then more and more unusual things started happening where expensive purchases of branded handbags started to appear in the house. And the handbag that appeared was sent from Indonesia. So when the son started asking more, mom had started a relationship with a man in Indonesia. And the son was very, very, very concerned. And when he looked at the bank account and the balances, mom had sent over $20,000 to this man in Indonesia. So they were sitting in my clinic room and they were just arguing about it because my patient had no insight at all. And to her, this was a romantic relationship, while the son was very concerned that this was a case of elderly fraud. So poor financial decision making or problems with money is one way that my patients present. So with all this going on, you can imagine she's very upset that the car has disappeared. She has managed to ask her grandson to give her the keys of the family car, and she's been going out without a license. Yeah, and the grandson loves grandmother and would do anything for her. So he was very conflicted. And imagine her daughter who was living in the same house. She was very upset because the grandson was taking exams, and grandma's behavior was really affecting her. So there were other issues within the family because my patient was calling other children and complaining about, it was causing some discord in the family. So these are the challenges facing someone who has early dementia. And very often the other children, dementia is a huge diagnosis. And at times I find that there is an element of denial. So when there's one child who my patient is sort of confiding things in, sometimes they don't believe that this is dementia and they think that, it's just family discord. So Junus talked about elderly suicide, and I think it's a very, very big problem. We know that it's increasing with the pandemic because what happened to my patient was that because she had stopped her the adjunct teacher job that she did, and the volunteer job that she was doing stopped allowing elders to come in because of the fear of COVID. So she became very, very withdrawn. She started watching Korean drama, but then that's like a really passive activity. So after a while, she just became very unhappy. Her mood was low, and there didn't seem to be any place that she could go to that where she fit in, because she was very high functioning, and putting her in a elder care center or a daycare center may not be the most appropriate. So I really like the work that's being done in the community and what Junus shared. So the other challenge with looking after her was that and this is a very common way that my patients present, is that they get mixed up. So I have patients whose appointment is tomorrow, and then they come in to see me today instead, for example, and they get really upset when we're not able to fit in. So I always try to make some exception, because with dementia it can be quite challenging. I had a lawyer who came to see me because he had problems with double booking appointments. And it's quite interesting, because I've talked about early dementia. There is such a thing as a pre-dementia, where the person does not have dementia, but it's like a prodrome, like a disease that comes before dementia. So this lawyer who was concerned, he said, I was perfectly fine. I used to be able to manage 10 things. And now, I'm just like writing everything down, because I feel like I can't keep up. I can't be on top of things. So when I assessed him, he didn't have dementia. He didn't qualify to have dementia, but there are certain tests when you don't do as well as people who are as educated as you can qualify as having a pre-dementia, and you would need close follow-up, because there is a chance. So I just want to explain a little bit that besides pre-dementia, it's now recognized that there is a pre-dementia, which is what we call like a subjective problems with your mind or memory. And this pre-dementia, all the tests that I would do to assess such a person would come back as normal. So they say that the patient knows, the person who experiences these memory issues knows, but the doctor doesn't know. Yeah, so that's an exciting area of research and development, because the whole idea is there's no cure for dementia. It's important to diagnose it early. It's important to diagnose it early because they respond to treatment very well. So I'm going to go on to talk about the last part, which is how you can reduce your risk. If you look at the Lancet Commission, if you just Google Lancet Commission Prevention of Dementia, studies have shown that you can decrease your risk of getting dementia by 40%. It is a life course model, which means you start young. So when you're young, you try to get as much education as you can, because all of us will decline a little with age, but if you start high, then you will be protected. So there are other risk factors. So education in life is important. I mentioned that. Lifestyle, smoking is very bad for the brain. Alcohol has been shown to be very bad for the brain, and it's been known for centuries. So that should be avoided. Being obese, like having a high body weight, increases your risk. So if you don't move at all, if you don't exercise, that increases your risk at all. So I've put up this sort of scientific slide, which just shows how these risk factors, they can be divided into two parts, which is if you maintain yourself well, you have a high level of education, you socialize, and then you avoid any damage to your brain, that would help prevent dementia. So high body weight, as we age, we tend to gain fat around the abdomen. So that increases your risk of dementia. Just having diabetes increases your risk, and being overweight increases your risk of all what we call like your heart risk factors, and it increases your risk of cancer as well. So we really should be investing in our future self by maintaining a healthy body weight. I get asked, how much should I exercise? So there are exercise guidelines. I think it's really important to know that exercise isn't just good for our physical health, but it's the first line treatment for anxiety and depression. And we know in times of the pandemic, I mean, I have classmates who are psychiatrists and they are fully booked. You can't make an appointment to see them. So mental and emotional health, it's really, really important. We should look after our mind and our mood. Exercise, it works like an antidepressant. So people ask me all the time, is there an anti-dementia diet? What should I be eating? So any nutrition study, I like to, I heard it in a conference that it's like having a new building in the Singapore, in the skyline. So in the Singapore skyline, if you have like one new building, it doesn't change the skyline. So I would say if we start eating a more plant-based diet, we avoid processed foods, maintain a healthy body weight, there's no, turmeric definitely doesn't prevent dementia. So just maintaining a healthy body weight, looking after our mental and emotional health, avoiding depression, that helps. So I see a lot of sad older people, and having depression itself increases your risk. Depression can also be caused by dementia, and someone who is old and sad may appear forgetful, but this is not dementia, but depression itself. So it's something very treatable. I mentioned exercise as a first line of treatment, but definitely if you are depressed, if you suspect that someone is depressed, it is treatable and you should seek expert help. Okay, I'm coming to the end. I think I've been talking, I've used up my time. I've been asked to put in something about the lasting power of attorney. So this is just something that we should do to protect. It's just like how you would have a will, for example. So having a document like the lasting power of attorney just give someone you trust. So that could be a spouse or your child. To have the power to make decisions on your behalf when you no longer have capacity. And that just makes things simpler because your spouse or child may not have to go to court to make decisions for you. So Junus recommended a book. I would recommend Atul Gawande's Being Mortal. It talks a lot about our mortality. There's a lot about geriatrics inside as well. So Atul Gawande is a doctor, but all his books are worth reading. He's a really gifted author. The other book I would recommend is this book called I Shall Not Hate. It's about Gaza's doctor's experience and how, I really like the book because he really comes out not more than a doctor to sort of reach out to ease the suffering around him in many ways. So I would love to connect to answer your questions. I'm on multiple social media platforms at geriatrician.sg. If you have any questions about geriatrics or training or dementia, I would love to answer it later, or you could send me a message online. Thank you very much.
Thank you very much, Farhan. There are actually quite a lot of questions that are built up already in the chat, and we will take them at the end of the session, so you can have a look through that too. It is now, again, my honor to introduce our next speaker, another national treasure, as I like to call all these young women doctors. I would like to introduce Dr. Suraya. She is an associate consultant orthopedic surgeon from Singapore General Hospital and a fellow Hadley House person like me. Popo people rule. Suraya is very unusual young lady. She also has 4 children. So between her and Farhan, they have 8 children. I think that is fantastic. They're both amazing doctors. What's also very special is that Suraya is an orthopedic surgeon, and that is such a difficult field, I think, especially for young women, juggling that, the long theater hours, the very nature of the job itself. But she is an amazing young lady. She has clinical appointments with all 3 medical schools in Singapore. And on top of not just going into general orthopedic work, her subspecialty interest is actually in bone tumors and soft tissue sarcomas of the limb. So she's going to speak to us today about our knees. So some of us are old enough to have creaky knees. Some of you are very young, but I'm sure we all need to know a little bit more about it. So the time over to you, Suraya. Thank you.
Thank you, Dr. Goh. So the title of my talk is Giving Your Joints the Love That They Need. I'll just start with a little bit about myself. As Dr. Goh said, I'm an orthopedic surgeon. I'm 38 years old. I went to Temasek Primary School. I was known as the most talkative girl on the bus, something which I think has persisted until now. This is a picture of me and my 3 brothers. It was quite fun growing up in a household full of boys. It was always a lot of rough and tumble. And I think maybe that's contributed to my becoming an orthopedic surgeon. So in the background of this slide is actually a picture of my mom and all 4 of us with the first doctor in my life. And she's Dr. Chan Sing Kit. who was my pediatrician. I was in RGS until 1999. I was in Hadley House, football rules. I was also a prefect, and some of the pictures of me when I was much slimmer and much younger. I was also in the Angklung Orchestra, really fun. I was the president for 2 years, and I was also in the RGS Malay Society. Still more about me. So after RGS and a short time in RGC, I went to Imperial College to pursue medicine. I also did an intercalated BSc in the 3rd year of medical school with a first class honors in healthcare sciences and management, which seems to be very trendy at the moment. I then came back to Singapore to serve in Sing Health, and I entered my orthopedic residency in 2011 after I had my first child, and she was 6 months old at the time. So there's a picture of me on my graduation day with my husband and some of my best friends from medical school. And in the bottom right is actually a picture of my whole class in medical school. There were over 300 of us. I am currently an associate consultant at Singapore General Hospital. As mentioned, I am a clinical faculty of all 3 medical schools in Singapore, and I enjoy teaching medical students. There's a couple of pictures of me when I'm operating. There's a picture of me holding one of the biggest tumors that I've taken out. It's about 4.5 kilos, slightly bigger than a newborn baby. A picture of me at a conference overseas, as well as preparing to do a case in OT. So my career is not just about cutting people and doing operations, but I also do a lot of teaching in the form of professional courses. So I teach with the AO Trauma, that's an international organization of orthopedic surgeons who specialize in teaching young surgeons how to fix fractures. And I do instructional courses as well as present at conferences overseas. I've operated when I was heavily pregnant. As you can see there, I'm just about a week before delivering my 4th child last year during the pandemic. I'm married to 4 kids. I can cook a mean steak. I love traveling, I love fashion, I love beauty and women's wellness, although traveling seems like a very distant memory at the moment. And as Farhan said, I'd like to echo that juggling everything is definitely not easy. It's important that I have a really strong tribe of people who help to support me. I think my mom is actually signed on. She's a great support of mine right from day one. So being a surgeon is not easy. There's definitely long hours. In fact, I just finished my training a couple of years ago, which means that since my schooling years, I've been taking exams every single year. So frequently, a lot of people take a lot of time to complete surgical training. It's a bit longer than medical training. There's lots of exams, long hours. We do lots of on-calls. So it's not easy to have 4 kids as well as juggle this hectic lifestyle, but it's doable. Orthopedics is traditionally a very male-dominated field. Worldwide, there are less than 5% of female consultants in the orthopedic fraternity. So the reason why I chose orthopedics is a frequent question, why go into such a male-dominated field? Well, I'm very good with my hands. I enjoy fracture fixation and playing with all the different toys that orthopedic surgeons get to play with, like drills, saws. We've got lots of different implants that we can use. I've got a passion for curing cancer, which is why I've decided to subspecialize in orthopedic oncology. And the fact that it's a traditionally male-dominated field is a personal challenge for myself. And I feel that if they can do it, I can do it. And I'm glad that I've come this far in this field, although there's still a lot for me to learn. And truth be told, it was a serendipitous thing because initially I had planned to do either plastics or breast surgery, but I was lucky enough to do a posting in orthopedic surgery, and I absolutely loved it and I never looked back. So I've chosen to talk about degenerative joint disease, specifically about knee pain. And the reason why is because, as we've already seen from the previous 2 speakers, Singaporeans now are generally healthier than they've ever been our life expectancy is increasing year on year. And rightly so, we should expect to live a better quality of life. I mean, who wants to be a 95 or 100 and bedbound, having someone care for you all the time? That's not what anyone wants. Unfortunately, joint pain comes to everyone. It's part and parcel of getting younger, as I like to tell my patients. So it's a topic which will affect every one of us at some point in our lives. So this is just a simple graph showing how the life expectancy has increased year on year. And at 2020, the average life expectancy of a Singaporean resident born in Singapore was about 83.9 years. So it's a long length of time to live. And if I were to be 80 or 85, I'd want to be able to be active and do the things that I love, instead of being cooped up at home and dependent on someone else to take care of me. So knee pains. What is osteoarthritis of the knee? Basically, it's wear and tear of the knee joint. It's mainly age-related. And research has shown that everyone above the age of 60 has some form of osteoarthritis of the knee. Basically, as you can see in the picture, the cartilage is worn away. There are lots of bone spurs. Sometimes you might get cysts in the bones. And there are some changes that we can see on x-rays. So this is a typical picture of progression of osteoarthritis over the years. Initially, it might start with just one compartment or one part of the knee being affected, but over time, it tends to involve all three compartments, which are the inside or medial or lateral, as well as the compartment underneath the kneecap. Now, why does the knee wear out? Mainly, it's due to cartilage degeneration. Now, cartilage is really just made up of a large proportion of water, as well as some specific cells. And drying out of the cartilage cells causes degeneration of the cartilage. There is a contributory role to the bone and muscle that support the cartilage. And there are some inflammatory substances which can also cause accelerated wear of cartilage. For example, if the patient has gout. So some reasons why a knee wears out, it could be biomechanical and biochemical. So for example, if there's too much weight or too much pressure that is going through the knee, for example, if someone is very obese, then that can accelerate the rate of wear and tear. Other biomechanical factors, such as if there was an infection there, or if the patient has a history of gout, these can alter the chemistry of the cartilage and cause it to wear out quicker. So if you have good cartilage, it's almost like you're walking on water. Good cartilage is juicy and plump, is full of water, and literally it allows your knee to glide as you're walking. So it feels like you're walking on water. So when osteoarthritis happens, it's because the breakdown of the cartilage exceeds the synthesis of the cartilage or the repair of the cartilage. Now, repair of cartilage is really suboptimal. Our body isn't designed to repair itself in that way. And therefore, once it starts to break down, it's really kind of a one-way street. So what causes people to be more prone to have osteoarthritis? Some people are born with alignment problems. So some people are born with knock knees or pigeon-toed. So as you can see in the picture of the three limbs, sometimes their legs are not straight. And that can lead to them having earlier osteoarthritis. If you've had a history of previous injury, for example, a fracture or an ACL ligament tear, that can also predispose you to getting arthritis earlier. Any previous surgery to the area can also cause that. And of course, obesity. I think that's been mentioned many times, and we all know that obesity is a huge risk factor for lots of different diseases, including one of the major risk factors for most cancers in the developed world. It's also a huge risk factor for osteoarthritis. Well, there is also a small genetic component which can predispose some patients to having osteoarthritis. So what are the specific factors that cause knee pain? Number one can be osteoarthritis, which is wear and tear of cartilage. There are other things within the knee besides just cartilage. There are some rubber-like shock absorbers called the meniscus. So if these are torn, then they can also cause pain. Torn ligaments can also cause pain. If you have a history of hyperlaxity or having loose joints, that can also cause additional pain. And if you have any loose bodies or any chondroid fragments, that can also cause pain in your knee and cause locking. There are some rarer causes of knee pain, which I won't go too much into because they really are quite rare, but some forms of rheumatoid arthritis or those related to other joint pains can be a cause of knee pain. if you've had a history of infection in the knee or a very bad fracture which involves the joint, or some other medical conditions, such as if you have a tendency to bleed, yeah, that can also cause increased knee pain. So what do patients feel? So apart from pain, patients will also come with a deformed looking knee. Now, this is a very extreme picture, but most patients won't wait till their knee looks like that before they come and seek medical attention. Most of the time, the deformity is a gradual thing that happens. So initially, their knees are straight, and then it slowly starts to curve as the arthritis progresses in one of the compartments. Sometimes they might come with a swollen knee that's painful. Sometimes they just come and say, oh, I feel that my knee is very stiff, especially after I've been sitting for a long time. Some patients aren't able to bend their knee very far, or frequently a lot of my Muslim patients say, oh, I'm not able to squat on the floor or kneel on the floor when I'm praying. So these are some of the very common complaints that they have. So when you see a doctor, for example, if you see me and you're complaining of some knee pain, your doctor will usually order x-rays. I mean, orthopedic surgeons love x-rays. And this is a picture of typical x-ray of someone with worn out knees. This is what someone's knees might look like, and the x-rays correlate to what we see on the patient. I mean, you don't have to be a doctor to see that obviously that knee looks quite deformed. The joint spaces are completely gone. So this patient has quite severe arthritis. Now, are you at risk of having arthritis? Well, yes, if you have knee deformities, if you're overweight, if you've had previous injuries, and just by virtue of being, as we get older, the likelihood of having arthritis does increase. Okay. So what can we do if you have arthritis? There are lots of things that you can do for yourself. So firstly, with the change of lifestyle, you can start by reducing your weight. You can start by doing some exercise, such as range of motion and stretching, as well as muscle strengthening. And then the doctor might move on to giving you medications. So things like paracetamol, which gives a very low level of pain relief, as well as some non-steroidal anti-inflammatory drugs. I think many patients have taken Ponstan before, or Acoxia. These are very good at reducing inflammation and swelling around the knee. A lot of my patients ask me about supplements such as glucosamine, chondroitin, and I feel that these are not harmful to most patients. However, the effects that this has on the patient's knee is probably quite limited. So while I don't actively encourage my patients to take it, if they come and ask me, is there any use in taking it? As I usually tell them that, yes, there's no harm to take it, but if it doesn't work after the 3 to 6 months, then I would suggest to stop it. So these are some pictures of glucosamine, chondroitin. There are other supplements. I don't really think that collagen or supplements which are digested by, if you eat collagen, it's just digested in your tummy. It doesn't actually go to your knee and form more cartilage. So I wouldn't recommend taking that. But certainly glucosamine and chondroitin are safe to take. So the last thing that we do try before going into surgery is that we do sometimes give injections to the patient. Sometimes we give an injection of a lubricant substance called hyaluronic acid, and that's similar to the fluid that's found in your knee. Now, that doesn't reverse any knee arthritis, but it can help to make the knee feel better. It's really quite a symptomatic treatment rather than curative. Sometimes if the patient is not willing to have any surgery, we do also inject some cortisone into the knee. Now, physiotherapy is a very important part of treatment. What happens in physiotherapy is that we advise the patients to go for muscle strengthening, to help with mobilization of the stiff joints, to stretch out any stiffness they might have. We also recommend them sometimes to go for heat or cold treatment. And it's important to optimize your muscle strength as well as how much your knee can move before you go for any surgery. And you can do this at home by yourself. I mean, a lot of the exercises are really self-explanatory and very simple to do. We don't need any extra equipment. You can just use your own body weight. It helps to keep your muscles in good shape. It helps to build up strength and fitness, and it definitely helps to reduce stiffness. So even if you're not planning for any surgery, this is good to do for your general muscle health and muscle strength. So as a surgeon, my favorite part is, of course, to talk about surgery. And the treatment options are varied. So we can start from something as simple as doing arthroscopy or keyhole surgery, and we move up the ladder of surgical complexity to sometimes doing corrective osteotomies. Now, osteotomies are not replacement surgeries. What we do in osteotomies is that we try to correct the alignment of the bone without replacing any of the bone that you have. And if the patient is not suitable for that, then we do go on to talk about knee replacement. So arthroscopy is really reserved for patients with early to moderate osteoarthritis. So if you've come in with a knee which is severely deformed, your cartilage is all gone, then you're not going to be suitable to have a scope. Basically, it's just to wash out the knee, maybe to debride some of the debris or frayed edges of the meniscus, and maybe to repair some small areas of cartilage damage. So if the cartilage damage is very extensive, then keyhole surgery or arthroscopy is not suitable for this patient. Even if the patient is, or you're suitable to have a keyhole surgery, most of the time it's just an option which buys time. So we usually advise the patients that it might take 2 to 5 years before you might need another surgery, which would be a knee replacement. Most of the time, the cartilage that's already worn out can't be replaced. And we're just sort of buying time and making the patient feel better before they need a knee replacement later on. I did mention about realignment surgery, and that's when we try to correct the deformity. And this kind of surgery is really reserved for someone who's quite young, whose cartilage hasn't really worn out yet. And what we're trying to do is to correct the alignment so that we can prevent the severe arthritis that will come if we leave the problem untreated. So it's really for younger patients. You need to have very good motion of the knee. So if you're walking in, kind of waddling, then it's not really suitable for you. And this is what a realignment or osteotomy surgery would look like. So I come on to the crux of what we do as orthopedic surgeons. It really is one of the most common surgeries that an orthopedic surgeon would do, which is a knee replacement. So we call it a knee replacement because we replace the surfaces of the knee. We do remove some bone from your knee and we replace it with a metal implant. Most of the time, the implants are made out of cobalt chrome, which is extremely durable. It's quite lightweight, so patients don't really notice a difference in the weight of their leg when they're walking. And it's really reserved for patients who have advanced arthritis and who have failed other medical treatments or physiotherapy. So the proportion of patients who need a knee replacement will probably be in the range of 20 to 30% of all the patients that we see. By and large, most patients are able to improve with physiotherapy, with medication. And so that's what we start off with first. So these are the components of a knee replacement. There are quite a few of them, but basically there's a metal component which goes at the bottom of your thigh bone. There's a metal component which goes at the top of your shin bone, and then there's a very smooth piece of plastic which goes in between the two pieces of metal, and it allows the knee to glide very smoothly when you're walking. So it's called a total knee replacement because we have to replace all parts of the knee, which are the femur bone, the bottom part of the femur bone, which is the thigh bone, the top part of the shin bone, as well as the underside of the kneecap. Yeah, so all parts are replaced so that when you're walking, it's a smooth movement and you don't feel any pain. This is a highly successful operation with over a 50-year track record in literature. It's the most successful procedure for knee osteoarthritis with predictably good outcomes of 90 to 95% of satisfaction rates. So since the first total knee replacement was introduced about 20 to 30 years ago, surgeons have come up with a half knee replacement. Now, this kind of knee replacement is reserved for patients who only have arthritis in one part of their knee. It's quite a waste, you might think, to sacrifice parts of cartilage which are still good, and that's why in some patients we choose to do a half knee replacement. And the benefits of doing this are that it's a much smaller surgery. Patients recover much quicker. It preserves your range of motion. So for patients, for example, Japanese patients or Muslim patients who want to kneel when they're praying, or when they want to go to church and they want to kneel, the results are much better for that compared to a total knee replacement. Recently as well, we've gone towards making smaller incisions on patients' knees. It allows a patient to recover much faster after the surgery. And of course, it looks aesthetically more pleasing as well. We also use computer navigation to improve the accuracy of our cuts and to improve the alignments of the knees after surgery. And this is what we sometimes use to help us. And the results are very good. Total knee replacements, more than 95% of our patients report good or excellent results. With a unicompartmental knee, which is the half knee replacement, 85 to 90% of patients report good or excellent results. And the only reason for that is that after 5 to 10 years, these patients tend to develop arthritis in the other part of the knee, which is not operated on. And then they will need a second operation to a total knee replacement. But for the time that the half knee replacement is being used, it's got very good results as well. The other surgeries, which are the realignment surgery and the keyhole surgery, they tend to have less predictable results. So treatment depends on what your needs are. We don't prescribe a total knee replacement for all our patients with knee pain. Everything is made to measure and everything is dependent on what the patient needs. So as you can see, there are different sizes of handbags, different sizes of shoes, different sizes of everything. And it's the same with medical treatment. No one size fits all, and we tailor all our treatment algorithms to what each patient needs. So I just wanted to talk quickly about the cost of a knee replacement in Singapore. The average cost before government subsidies is just under 30,000, roughly. And this is for A-class patients or private patients with no subsidy. So if you were to go for a knee replacement in a restructured hospital as a subsidized patient, the cost would be, after government subsidy, about 10,000, of which the Medisave deductible would be about 3,000, and most of the time the patients pay out of pocket about 1.5K. For a C-class patient, sorry, I think that's been reversed. So for the B2 patient, you pay slightly more, which is 2.5K. And for a C-class patient, obviously you'd pay less because you'd get more subsidies. So this is just a rough cost. 28K or 30K is really quite a ballpark figure. And that is the cost in a private hospital as well as in government hospitals. But as you can see, the amount of subsidies that you get from the government is really quite massive. And on top of that, you can also use your Medisave to deduct further so that the out-of-pocket payment, if you're a subsidized patient, is quite affordable for most patients. I just wanted to quickly talk about where I work, where in commemoration of SGH's 200th year anniversary, the Department of Orthopaedic Surgery is doing a knee initiative where we're sponsoring 200 total knee replacements for patients who are needy and are unable to afford it. So if anyone is interested in sponsoring patients to go for knee replacement, please do get in touch with me and I'll be happy to give you more information. But my take-home tips for joint health are that most joint diseases are due to wear and tear, which means that it's extremely rare for you to have knee arthritis from rheumatoid arthritis or from infection. Most of the time, it is due to osteoarthritis, degeneration, and wear and tear as you get older. I would recommend to maintain your joint health by keeping trim, which means to eat smart. Don't eat lots of processed foods. Reduce your sugar intake, no oily foods. Try and eat plant-based, as Dr. Farhan recommended. I would say to keep active as well. And it's not just cardio. In fact, I usually recommend to my patients to try and cut down on the cardio because most cardio tends to be quite heavy on the knees. So I would recommend, if you want to do some cardio, it would just be brisk walking. I don't recommend to do jogging once you're over the age of 65. If you have not been doing that for the rest of your life. If you've been running marathons, please, by all means, you can go ahead. But if you're going to start exercising, I wouldn't start by running. I would recommend more things which are less impactful on the knees. So things like swimming, yoga, Pilates, things which do incorporate a little bit of resistance training. You can use your own body weight. You don't need to get you don't need to get dumbbells or heavy weights, but you can always start slow and try and build up if you're keen to get more fit. I didn't touch on osteoporosis because I think that's been covered in a different webinar before, but I would say that bone health is important as well because the joints are at the end of the bones. And if the what's supporting your joints is not healthy or not strong, then your joints are going to suffer as well. So bone health is extremely important. Asians have a very high incidence of osteoporosis. So I would urge everyone to supplement with calcium and vitamin D, which a lot of us are deficient in. Thank you for listening. And you can follow me on Instagram, TikTok, and Facebook. I'm also on all the social media like Dr. Farhan. In fact, it was Dr. Farhan who introduced me to TikTok. Or you can just email me at suraya@doctors.org.uk. Thank you.
Thank you very much, Suraya. That was a fantastic session that we had. And I think you made things very easy for us to understand. And indeed, so with Junus has talked about being, socially active, and Farhan's talked about being mentally active and engaged, and Suraya has given us a great session on keeping physically active and what are the do's and don'ts. And our last speaker, but certainly not the least, Ms. Ming Jing, is going to actually talk about being financially healthy. And I think this is a very important topic. There's an awful joke, isn't it, that you can afford to die, but you can't afford to live and be unwell in Singapore. But I think Ming Jing has got a lot of insights into some aspects of healthcare financing that a lot of us may not be so aware of. Ming Jing is currently the Director of Population Health Management at National Healthcare Group. She's from the class of 2002. She puts their Richardson House, but she's a very modest young lady. She's actually the Richardson House captain in her days. I think she's a national swimmer as well. She's been in public service for more than 10 years, ranging from finance to manpower, and we're very happy that she's now in health. And I think she finds a lot of meaning in designing and implementing public policies to serve the public good. Now, Ming Jing previously worked in Ministry of Health to design and implement something called CareShield Life. This is a new national long-term care insurance policy for disability that happens in old age. She's an expert on value-based care, and I'm going to hand the time over to her now. Ming Jing?
Thanks, Ian. That was a very kind introduction. Not really a national swimmer, but a school one. So really enjoyed that part of my life earlier. Let me just share my screen. The title of my sharing is, Am I Really Going to Need CareShield Life? And as Ian mentioned, I worked on the design and implementation of CareShield Life together with my team at the Ministry of Health from 2017 to 2020. My journey with healthcare, as Ian pointed out, I've been a public servant for a long time, and not always in health, but my journey with sort of this interest in health and healthcare policy really began when I started at the National Environment Agency in 2015. It was there that I got introduced to the importance of public health, maintaining a public health system in Singapore. At that time, we were fighting the Zika outbreak, which was one of the rare sort of crises before this current one that I experienced. And of course, they also fight dengue and public hygiene. After that, I then joined the Ministry of Health to work on healthcare finance and landed with this particular job of helping to design and implement this new long-term care insurance scheme, CareShield Life. And I think there's a lot of significance and meaning to this job because we see a lot of elderly in our daily lives that could actually benefit from greater financial support, but have to rely very heavily on government subsidies or also their children and maybe their grandchildren for financial support. In the future, as many of the other speakers have pointed out, the existence of children and grandchildren to support us will decrease. Our fertility rate has gone down and the old age support ratio has gone down as well. And a lot of us will no longer be able to rely heavily on that source. So we have to rely more heavily on each other as a society. And that includes collectively being responsible for this financial support through insurance, through national insurance schemes. And that's why I really thought it was a very it was a great opportunity to come here and sort of speak more about CareShield Life, which is a new national insurance scheme that was launched maybe a couple of years after CareShield Life was launched. So I think without further ado, let me just start on the presentation. I thought to highlight my grandmother's journey with aging. This picture of my grandmother, she religiously goes to the cemetery every year in April for what we call Ming. It's a tomb sweeping festival that we have. And it is to sort of pay respects to my grandfather who's been passed on for maybe 30 to 40 years. And she sort of leads the procession. My family will hire a bus and we all take the bus from her house to the cemetery and with uncles and cousins and all that, and pay the respects to my grandfather. And she's done it every year, even as she became progressively weaker and couldn't step off the bus and into the graves without support. So I took this picture in 2016, about a few years after she had a hip fracture. So she's been very, very independent her whole life, but she really became weaker in 2014 when she had an accident. She was in Geylang to visit a temple, which she goes regularly on her own, even though she was already 90 years old. She took a bus there. And as she was crossing the road, a car knocked into her by accident. He was making a turn, didn't see her, and then it was a very, very slight knock, but she fell. And that resulted in a hip fracture and hospital stay and also weeks of rehab after that. After that, she became progressively weaker. She never really quite recovered full function. Started to need a lot more assistance with what we call daily living activities, which means sort of moving around or going to the bathroom, getting up from, let's say, the bed to the chair and stuff like that. She was also diagnosed with dementia in 2016 and became a little bit more agitated in daily life. She would scold strangers, or if, let's say, my mom's helper went over to help out to take care of her because my uncle was not free, she would hit the helper or scold her. So she was diagnosed and put on some medication as well for the agitation. And my as we couldn't sort of keep her at home in the day, we then enrolled her in the daycare center at the dementia daycare. And then subsequently, she unfortunately grew even weaker and made multiple trips to the hospital for chest pain and shortness of breath. And in 2017, she passed away due to heart disease. To me, this was my first experience and very, very personal experience with the journey of aging and how actually we may end up needing long-term care, which is what we call sort of a mix of helping with daily activities and sort of personal care activities that you don't expect you lose because you're old, but it made it very real that actually a lot of us may need that kind of help as we age. And it happened right in the middle of me sort of working on CareShield Life. So it was actually a very impactful experience for me. And of course, throughout this whole journey, we had to be able to pay for her care. She didn't have a lot of insurance. She didn't have private insurance at all. So we were mainly relying on CareShield Life, which is the National Hospitalization Insurance Scheme. Quite a lot of government subsidies, especially because she's a pioneer. And of course, MediSave from family, because she herself never really worked formally throughout her entire life. So she had very little MediSave savings, but you can tap on family's MediSave savings for her care. So there's been a lot of discussion on how to prevent us from getting to that stage of aging where you actually need a lot of help and a lot of help and a lot of care in old age. And based on our Ministry of Health's data analysis and past data, plus some sort of forward-looking projections and referring to other countries' experiences, we actually estimated that 1 in 2 healthy Singaporeans aged 65 will become severely disabled in their lifetime and may need some kind of long-term care. When I mentioned this statistic, actually a lot of people are always very surprised, because if you look, in the streets, at hawk centers. We do see a lot of elderly now, but do you really see 50% of people in a wheelchair or needing help or being unable to walk? I mean, of course, the answer is no. But this stat is sort of a sort of lifetime statistic that you have to think about over the series of the rest of your life from the time you become age 65. And a good analogy I always use is, so maybe this morning, how many of you actually were at the beach at East Coast Park, taking a walk? Probably very much less than 1% or 5% or even less. But if you say, over the past year or over the past 2 years, or maybe from the time you were born until now, how many of you have visited East Coast Park? Actually, that number will be a lot higher. And that's how we think about this statistic as well. From now, when you reach age 65 till the end of your life, actually a good 50% of us will experience some kind of need for long-term care. And when we say severely disabled here, it doesn't mean that we lose a leg or we lose our eyesight. Actually, it refers to needing help or assistance with daily activities of living. And this includes things like, being able to feed yourself or dress, put on your clothes, because these are it requires quite minor motor movements and motor skills. Or it could be sort of things like walking across a room, or getting up from the bed and moving onto a chair, going to the bathroom, as well as taking a shower. And you never really think how much you value such activities until you actually need help with them, I think. Of course, I really hope that actually all of us take heed of what the doctors, Farhan and Suraya, have said, and of course Junus as well, about trying to prevent this from happening. And I also hope that the statistics are eventually wrong. If we do, as a nation, manage to sort of bend that curve and become healthier and prevent this from happening, actually everyone at the Ministry of Health will be more than happy to revise this statistic. But for now, this is what we are looking forward with. Yeah. So the schemes that I mentioned, CareShield Life, is actually a basic long-term care insurance scheme. It is preceded by another scheme called ElderShield, which many of you have heard because you receive a letter at age 40 that says you are now enrolled into ElderShield, which is sometimes a bit jarring because you don't think you're very old at age 40, right? But really the scheme, ElderShield, was named because it was meant to protect you in old age, and not to say that you're old at age 40. But I'm really sorry about that, the naming. But so that's why we've sort of, the new scheme removed the word elder and called it CareShield Life instead. But both schemes are really sort of long-term care insurance schemes that provide monthly cash payouts in the event of severe disability, especially in old age. CareShield Life is new. It was introduced in October 2020 as an enhancement. And of course, this is very basic national insurance scheme that everyone buys into. But if you do want additional coverage, you can buy supplements from private insurers. So how does ElderShield work first? Because that's actually the basis of how CareShield Life was designed, and CareShield Life is an improvement. So ElderShield, you are auto-enrolled at age 40. You pay annual premiums from 40 years old to age 65. At age 65, you stop paying premiums. But I must also emphasize that actually, even after you stop paying premiums, your coverage continues on for life. So it means that at age 70 or age 80, where actually you are most likely to weaken and need help with your daily activities of living, you are still covered under ElderShield, and you can also start claiming at that point for ElderShield cash payouts. So the claims criteria is if you become severely disabled, you can make a claim. And technically, that means that you are assessed by an assessor, a disability assessor, which could be a GP, could be a physiotherapist, that you are not able to do 3 out of 6, the 6 basic activities of daily living, which I mentioned just now: eating by yourself, putting on your clothes by yourself, going to the bathroom, showering, walking across a room, as well as transferring from a bed to a chair and vice versa. So if you cannot independently do 3 of these, you can actually make a claim under ElderShield. So there were 2 versions of ElderShield. I know it's quite confusing, but the first one was actually introduced in 2002, $300 a month for a maximum of 5 years. And the second version, ElderShield 400, was introduced in 2007, $400 a month for up to 6 years. This product or this scheme is actually currently managed by 3 private insurers, Aviva, Great Eastern, and Income. But the government will take over its administration closer to end of 2021, just to make things a bit more seamless for Singaporeans, because it's actually quite confusing for this national scheme. It is a national scheme to be run by the private sector, appointed by MOH. So we sort of decided to bring it back the basic level of ElderShield and administer it in-house. What CareShield Life is, it's really quite similar. So it still provides cash payouts, and it still provides you protection for life, meaning even after you finish paying premiums, you will continue to enjoy coverage as long as, well, you will continue to enjoy coverage to the rest of your life. But the key improvements are, firstly, we've sort of extended the duration of payouts you can receive. For ElderShield, you can only receive cash payouts for up to a maximum of 6 years. But we do see people who need long-term care support for maybe as long as 10 years or more than that. And we thought that actually extending the duration of cash payouts that you can receive it provides much more assurance, because it's the worst thing, I think, to suddenly see a drop in income when you are already in the midst of a very sort of distressing health episode. So that's the first change. The second one is to increase the payouts, and ElderShield had a maximum of $400 per month under the older scheme. So for CareShield Life, it will be increased to $600 a month starting in 2020. But the payouts will actually increase over time, currently estimated at about 2% per year. So what this really means is that it sort of protects us against inflation. And I was sort of enrolled into the scheme last year. And what I will experience if I have to claim from CareShield Life in my old age, say around 70 years old, is that I'll probably get a payout of about $1,000 per month at that point, because my payouts have been increasing over time. Of course, then as a national scheme, the government has stepped in to provide subsidies so that no one will lose coverage if they cannot pay the premiums. This is a very similar concept to MediShield Life, where lower income get higher tiers of subsidies to sort of defray the costs of premiums that they have to pay. And if you're really unable to pay the premiums even after the subsidies, there's additional premium support for the really low income or unemployed to make that payment. And of course, premiums can be fully paid by MediSave, so no out-of-pocket cash needed if your MediSave savings are enough to pay for this. So just a sort of quick summary on who is covered under CareShield Life. If you're born 1980 and after, CareShield Life is compulsory and universal. And when I say universal, it means that it actually covers those with pre-existing disabilities. And this was one of the changes that we pushed for quite hard as well, because it actually helps this small group of people with adult disabled children who really cannot survive on their own. And at age 30, when they're enrolled onto the scheme, actually they receive an immediate sort of boost in their income at $600 a month to help with all their care needs. There's no underwriting sort of associated with CareShield Life for this group of people. So you're enrolled at age 30, except for the first batch of people born between 1980 and 1990 who enrolled between the ages of 31 and 40 in October 2020 last year. Now it's the confusing part. So if you were born 1979 and before, CareShield Life is optional for you because you were already auto-enrolled onto ElderShield previously. But you are able to enroll into CareShield Life or upgrade to CareShield Life from ElderShield if you are not severely disabled. I think as a summary, as the experience of my grandmother shows, actually ElderShield and CareShield Life is not enough to cover all your necessary healthcare expenditures. And that's why I put this on screen as well. It gives you a sense of how, as an individual or as a caregiver or as a family, we can cover our entire sort of spectrum of healthcare needs. And I've sort of divided them by care settings because I think that's more easy to understand. So if you have primary care needs, you can go GP visits, polyclinics, especially in old age where you have likely to have more chronic conditions, you likely want to stick to a particular family doctor or polyclinic and have sort of regular follow-up so as to prevent yourself from your condition from actually worsening and ending up in hospital with an acute episode. In that case, actually, there's support from your MediSave savings and there's CHAS for private GPs as well as polyclinic subsidies. If you do need to go to a specialist, MediSave can help with that as well as specialist outpatient clinic subsidies at public hospitals. If you do end up needing to go to the hospital for an acute episode and needing to stay in the hospital for a period of time, that is where insurance kicks in because that becomes a much larger bill, and that risk pooling effect within the whole population of Singapore actually helps to defray the costs somewhat when you actually meet with such an episode. So that's going to be quite key. And then for the co-payment and the deductible, which Suraya mentioned just now, MediSave can help to cover. And of course, there's a base layer of subsidies at the public hospitals. If you are in the B2 or C or even B1 wards. And then finally, long-term care where you're starting to age maybe, or you need daycare, you need home care, or you need a nursing home. That's where CareShield Life and ElderShield come in to help with cash payouts that you can use quite flexibly to sort of pay for a home care, or you might want to buy a geriatric chair, or maybe install some handlebars in the bathroom, or maybe a special bed. That plus grants from the government and subsidies, as well as some MediSave cash withdrawal, will help to sort of cover those financial needs as well. Yeah, so this is how it all fits together, and I think it is one downside of this sort of many payer approach that sort of Singapore has put in place, rather than the very sort of clean health system or health financing that other countries have put in place. In other countries where, for example, the National Health Service in the UK, where everything is free but tax funded, is that it gets very confusing because people don't know what I can use in what setting, and then how do I get information and access to each of these schemes. So I think MOH realizes that, and they've been trying very, very hard to make a lot of these claims as automatic as possible. Once you present at the hospital, once you present at the polyclinics or the GPs, if they are administering some of these schemes, they automatically offer it to you, automatically make a claim back end for you. And even for CareShield Life and ElderShield, where you need some kind of assessment, a clinical assessment from either a GP or a physiotherapist or nurse to make a claim. We're also looking at how to make that claim more seamless. For instance, actually, it used to be the case that only GPs could make that assessment, but we sort of expanded the pool so that also physiotherapists and trained nurses can make that assessment. And we're trying to sort of increase data flow back end between different institutions and the Agency of Integrated Care, which is actually an agency helping us to administer this scheme. to make it such that if you have a assessment sort of done somewhere else, that same assessment can be used again to make a claim for the insurance scheme, or even better, that data can be passed back and you can automatically sort of qualify for a claim. And that's something that I think the Ministry of Health folks have been trying to work on, just so that people are not so bogged down by claims procedures, even especially at a time where you are already sort of quite distressed by a health episode or sort of needing to get help for long-term care needs. Yeah, okay, so that's the end of my spiel, and I just wanted to end off by saying I really find the healthcare field extremely meaningful and public service extremely meaningful. You can deal with a lot of very intellectually challenging issues, but that at the same time make a huge contribution to the lives of your fellow Singaporeans. So aside from, you know, selling my koyok about this new scheme, I actually wanted to also say that if anyone is interested in a career in public service, please feel free to reach out to me and find out more. Yeah, because I think it's a really meaningful field to be in. Okay, yeah, thank you. And more information, please go to CareShield.gov.sg. I'm not as media savvy as Suraya and Farhan. I don't have any TikTok accounts. I do have an Instagram account, but it's a private one. So sorry about that, but I can give my email to the organizers and feel free to reach out to me through there. Thanks.
Thank you, Ming, and you've made a complex concept really quite easy. And I think it's very important, good that all of us know that there are avenues of funding that's available, instead of just feeling that, you know, worried that you are going to be burdened with a huge bill for yourself or for your parents or the seniors who depend on you. So thank you very much for that sharing. So I'd like to actually direct some of the questions that have been posted in the chat box to some of our speakers today. Actually, Suraya, there are quite a number of questions on exercise in your knees. What are the do's and don'ts? So could I get you to answer some of those?
Yes, I'll be happy to. So could you read the questions to me? Sorry, because let me see. Okay, yeah. I'll scroll through the questions. Is it harmful? Is doing the following exercises harmful for the knee? Climbing stairs up slowly. It can be painful for some patients to climb up and down stairs. And if that's the case, then it usually means that it's the kneecap that's involved in the arthritis. So I would suggest that if there's a certain activity that is hurting you, I would try to avoid that. And I would focus on strengthening the muscles that can help to relieve that problem. So for example, if you're having pain going up and down the stairs, then you actually really need to concentrate on your quad strengthening, which are the big muscles in the front of your thigh. And you can start by really just doing exercises sitting on the floor. You can do simple leg raises. I wouldn't start by doing squats first, because that puts a huge strain on your knee, and you need to have a certain amount of quad strength to do squats properly. So I would just start with simple leg raises first. Only when you can do leg raises like 3 reps of 10, 3 times a day without any pain and without any difficulty, only then I would recommend you can go on to squats. So squats is kind of like a medium level intensity kind of exercise for the knees, and it's not easy to do it straight up if you've never done any exercise for the knees before. Next question. Let me see.
There's one about seniors tend to be stiff and fall easily.
Yes.
So, yeah, how do they maintain balance? What would you recommend?
Well, that's actually a multifactorial problem, meaning that there are many causes of elderly patients or seniors falling over, and being weak in the knees or in your joints is just one of the minor reasons actually that you can have a fall. A lot of time it's to do with their balance, or sometimes to do with spine issues. So if your main problem is that it's your stiff knees that is causing you to fall, then I will usually recommend to my patients who have sat down for a long time, they usually say, oh, it's really stiff after I've sat down for a long time. So I say before you're going to stand up, please just move your knee so that you get rid of that stiffness. Don't just stand up straight away and start going, because that's when you feel the stiffness and then your knee kind of seizes and then it gives way, and that's when they fall. So I tell them, for example, if they're just planning to get off the bus and they've sat down for like half an hour or 45 minutes. I usually recommend to them just, maybe 1 or 2 minutes before you're planning to get off the bus, just slowly start moving your knee. And that the movement allows some of the joint fluid to start lubricating the knee, and that also stretches out the muscles and it helps with the stiffness. But that's not the only reason why patients fall. So they need to be kind of clear why they're falling. Is it because of the knee or is it because of other problems? There was one question about chondroitin causing prostate cancer in men in the US. Actually, I'd like to clarify, because anything causing cancer that we say is okay to take, of course, that's a little bit worrying. There are some animal studies which have shown that chondroitin is overexpressed when you have prostate cancer. However, this chondroitin that they're talking about is non-sulfated chondroitin. We're going to get a bit technical here, but just to clarify, the chondroitin that they're talking about that causes prostate cancer is non-sulfated chondroitin, and this is very different from chondroitin sulfate, which we prescribe to patients or which you can buy over the counter. I think that in Singapore, the Health Sciences Authority is very strict, and they are very thorough in what they check and what they allow to be sold over the counter. And anything certainly that is cancer causing will not be sold in Singapore. In addition, this causing cancer is quite new research. It's not proven in large scale trials or even in any mainstream sort of journal. So I would say that chondroitin causing prostate cancer is not quite entirely accurate, if you don't mind my saying so. Is weight training contraindicated in knee health? Yes and no. So again, if you've never done any weight training in your life, then starting off with 50 kilo weights is really not a good idea, because you're going to injure yourself. But weight training is important because you need to train up the muscles. It's not just the joints. There are lots of muscles which are around your knees and your hip, which you need to train up if you want to recover well from any surgery, or indeed if you want to strengthen up your knee. So it's really important to do some weight training, but doing too much, of course, if you've never done it before, then definitely a bad idea. It's not just the weight, it's also how you do the exercise. So if you're doing explosive exercise, that puts an immense amount of pressure onto your knee or any of your joints, and we generally don't recommend that for people who are older. But if you're doing sustained weight training under guidance and supervision, then sometimes it's possible. So it's not contraindicated. How is the diagnosis of knee conditions carried out other than x-rays? So x-rays are really cheap and they're simple and they give us so much information. So it's my first investigation of choice. But in cases where the diagnosis may not be clear-cut or might need a little bit more investigation, we also do CT scans, we do MRI scans. If there are other conditions that warrant it, sometimes we also do bone scans and lots of other sort of investigations. But knee x-rays or x-rays are really one of the easiest and quickest way to investigate knee pain. Have I gotten all the questions?
Yeah, I think so. Thank you so much, Suraya.
Okay.
Could I ask Dr. Farhan next? There is a question on, you mentioned pre-dementia and pre-dementia. And if I could paraphrase the question, when someone comes with a bit of behavior change, whether they self-report it or whether the family reports it, how do you distinguish between when this is the beginning of dementia, or like you mentioned also depression? How do you know whether it's just aging or when it's a disease that you need to address?
So, I think that it's complex. Therefore, you need an expert to determine if this is dementia or not. Yeah. So I would say full assessment. I would look at their function. So you can think about it this way. If mom and dad can live alone without any help at all, you're not doing any groceries, you're not, you can say, Mom, I'm bringing 10 people over and mom can cook like a, 5-course meal. She can plan and do that. Then that isn't dementia. But very, very often, the early symptoms, they are very hard to detect. And family, they tend to be very protective. They don't want the diagnosis of dementia because it's so devastating. So I would need the full story, not just from the patient, but from a close family member, preferably one who's living in the same house. Yeah, because a lot of times, like the finances are hidden. Children don't know what's happening with mom or dad's bank accounts. Yeah, so a lot of information gathering on top of the clinical interview. Yeah, sometimes it's so difficult to determine, and then you would need more specialized testing like a psychologist. Yeah, so a neuropsychologist, I mean, my patients hate it because firstly, it's like 1 to 2 hours, a few times a week, like a few sessions, and it is a bit costly as well. But at times we need to get expert help to determine, is this pre-dementia? Yeah, but if it's pre-dementia, then really no test is good enough. It's just sort of follow up, making sure that we get in touch in like 6 months, a year, just to make sure that there's no deterioration. Yeah, I hope I answered that question. So the answer is actually like medical training, I suppose, or like years of experience.
Mm.
And as a corollary to that, if you suspect pre-dementia or someone suspects pre-dementia, is there treatment, or what would you advise?
So firstly, there's no cure for dementia. Yeah. And there's no evidence that dementia medication, which just slows down the disease, is effective in pre-dementia. So there is some evidence that high-dose ginkgo, this is like medical grade ginkgo, can be beneficial. But I mean, I must say that the evidence base is still not strong. Yeah. So I feel that one way to look at it is that we can do so much. We can do so much to prevent our risk, to decrease our risk. So we should focus on the 40% decrease. The 40%, you can decrease your risk of dementia by 40%. Yeah. And as humans, right, we always don't look at the sort of delayed issues. We always think of the immediate. So like at this point of time, it's just like trying to earn money, trying to raise my children, trying to like make sure the house, doesn't look like a tornado hit. But we should also invest in ourselves, and that includes like our mental and emotional health. So there was a question in the chat group which says, how do we know that above 40, it's not like an aging or memory issue, but it's just stress, it's just stress, or I think the question was, is it just stress and a terrible lifestyle or something? Yeah. Is it just a stressful life? So stress is normal. But if you're sleeping very little, there's more and more evidence that sleep deprivation increases your risk of dementia. There's very strong evidence that if you treat all these sleep issues, if you are having insomnia, for example, and you take sleeping tablets, your risk of dementia increases tremendously. Yeah. So I would say that stress is the normal part of everyday life. But if you're having issues with your mood, if you're not sleeping, I mean, these things just kill your brain. It increases your risk of having memory issues, of having dementia.
Thanks very much, Farhan. Jog, did you want to ask?
That's a very sobering thought.
Yes. Yes.
Yeah.
But thank you so much, Farhan and Suraya, for taking the questions from the floor. And thank you, MJ and Junus, for the great sharing. In the interest of time, there are 2 more questions that I have for you. And one is directed at MJ, Ming, which is, how does one convert, or how does one sign up for CareShare for those born before 1979? Because CareShare is an excellent scheme. The government has set up really great schemes to help, with the healthcare needs, post-retirement. So how does one convert to CareShield for those who are born before 1979?
Yeah, thanks, Sean, and thanks for the question. The scheme is not open for those born 1979 and before yet. I expect the Ministry of Health to release some information on this soon, hopefully by the end of this year, so that everyone in that age group can sign up if they want to. Just to also share that actually, if you're currently on ElderShield and sort of born between 1970 to 1979, you will also be auto-enrolled onto CareShield Life, so that it's sort of easier for you. You receive a letter to say, if you don't do anything about this, you will be auto-enrolled onto CareShield Life. So do look out for that communication from the Ministry of Health, hopefully by the end of this year. Yeah.
Thank you.
Hi, this is Kami.
Yes.
Yes,
Yes.
I want to thank the alumni for having such a fantastic webinar. I really enjoyed myself. Just to add something to Farhan's, sleep is memory consolidation. It's very important, and DNA repair. So try to get make sure you get enough sleep. Of course, exercise. I do step, I do Zumba, and I dance every day. Not at the same time, but different things every day. So I think that's important.
Yes.
And I'm 81.
Yes.
Yeah.
You put us all to shame. We love you. You're the best.
I want to congratulate Farhan and Suraya. I mean, you're so brilliant.
Oh my God.
I learned so much from both of you.
You're the best. Mrs. Lim, you are my principal. I love you so much.
Yeah, you're my principal too. You called me by name.
Wonderful. It's so wonderful to see you all, to hear you. Well, I have a gold card. I don't need all your special CareShield or whatever shield. So I'm covered.
Thank you so much.
I think very few of you are in my position. So I'm a CSC. So they call it the gold card, you know.
Yes.
Everything I do is, but I also have both total hip replacement.
That's amazing, because Mrs. Lim and I,
I'm still dancing,
RGS,
yeah.
yes, a whole group of RGS, and we just did a flash mob for the annual.
We just did one, and a job part in a virtual flash mob. It was so wonderful.
Yeah, Mrs. Lim choreographed the entire thing. She's an inspiration as well, above 80, and you know, she's so active and so engaged, and we're both taking a course together on music videos.
Yes, I did quite a few.
And I've got a last question, which is a beautiful question for Auntie Betty, who is a grand old age of
Hi, Betty.
She's our elderest RGS Alumni lifetime member. Auntie Betty, this is a question for you right from Stanford. Natalie has asked you this question. If there is one piece of advice you'd give to working women, what would it be? There are many working women among us now. If there's one piece of advice you'd give to working women, what would it be? Auntie Betty, could you unmute yourself? And
yeah, you got to unmute yourself. You're muted. Yes.
Pearl of wisdom. We're all waiting to hear from you.
Am I muted now?
No, you're fine. Great. Nice to see you.
Yes. What was the question?
The question is this, Auntie Betty, if there is one piece of advice you'd give to working women, what would it be? Advice for working women. One piece. I'm sure you have many pieces of advice. Please go ahead.
Well, I think you must have time for yourself. Always remember that. Don't work yourself to death.
That's a great answer. That's a great answer. Yeah. Thank you so much. Yeah.
Okay.
Make time for yourself. So on that very high note, you know, making time for yourself, women and gentlemen in our group who care about this whole idea of adding life to our years. We just want to thank everyone for attending. Most importantly, also, I want to thank all my beautiful speakers, Junus, Farhan, Suraya.
Thank you.
Ming, thank you so much for sharing your thoughts with us. We've learned so much from you. And for those of you who have questions, please continue to send us those questions to the email that we've given you when we register. And for the RGS girls out there, RGS alum, you'll notice that our virtual background has a QR code. Please bring up your phone, scan the QR code, and join RGS alumni to continue our legacy of excellence for future generations of RGS. Together with my co-host, Dr. Goh Soo-Yen, I want to bid you guys a very good afternoon, and thank you once again for joining us. Thank you.
Thank you.
Congratulations to all of you.
Thank you.
Yes.